Kia ora, I'm Dr. Helen Fulcher and I'm talking with Professor Bruce Arroll, who's the director of the Goodfellow unit. Welcome, Bruce.
Thank you.
And today we're talking about FACT therapy. Can you explain what that is?
Well, FACT therapy is an abbreviation of Focused Acceptance and Commitment Therapy, which is acceptance and commitment therapy applied to the clinical setting in a focused and brief time.
Okay, so how does it apply in primary care? What do we do?
Okay, well, the classic situation is you've got a patient in front of you and you're feeling a little bit stuck. They're distressed and you're not sure where to go with them.
Yeah.
So rather than doing a PHQ-9 or a Kesler, I suggest people do a thing called a work, love, play. Now, these forms are available in my clinic on our computer, but they're also available on my website, which is www.brucearroll.com, and it's all free and it's there to be downloaded. So what this does is you get the patient to do, it's 5 questions, and it's how are things going in your work or everyday life, 1 to 10 scale. How are things going with your friends, 1 to 10 scale, 10 being good, 1 being terrible. How are things going, intimate, love as an intimates, how are things going with your partner if you have one, 1 to 10. How are things going with your family, 1 to 10, and play. And then there's a whole bunch of questions which I ask about exercise, sleep, substance use, gambling, violence, social community contacts, clubs and things, spiritual component. And then the last question is about, I would say to somebody, do you have any unresolved traumas in your life that you would like to talk about today? And they fill that in. That gets scanned into the note, so I don't actually have to write anything. So there's a lot of information there. Now, a score below 35 on those 5 questions correlates very highly with a PHQ-9 score in the depressed range, whatever that means.
Yeah.
But it certainly means the patient is distressed and a bit flat.
Struggling, yeah.
And in that questionnaire, there's always things you can do. They never straight line at 8 out of 10. It's what I call a sawtooth pattern.
Yeah.
And they'll be doing things, if they're very flat, they'll be spending more time in bed, which they have to stop doing. Being in bed when you're not asleep is not good for you. Get out of bed. Don't go and hide in bed when you don't feel like it, even though your brain will be telling you to if you're flat. I get people exercising and reducing substances, because what people do when they get distressed is increase their substances. And I say it's not a moral thing. I don't care if you drink alcohol or smoke cannabis, but they're not, smoking 7 joints a day isn't good for your health. Drinking alcohol all day is not good for your health. And we've done a little randomised trial in our clinic. It's very effective. Numbers need the treat of 3, and that's for better outcomes at a week.
Wow,
So
that's fantastic.
So it's pretty good, yeah. So it's interesting stuff.
And so how do you get your patient to engage in it? Bruce, what's your tips for?
What's my tips? Okay, well, this is the next thing that's quite important, is you say, well, would you be interested in doing something in the exercise department? And I really think exercise is a treatment for everything.
Yeah.
It has got a lot of benefits. And I say, what would you be willing to do? Oh, okay, I'll go to the gym every day of the week. So there's the key point. How likely are you to do that? 5 out of 10. 5 out of 10 probably in my book isn't going to happen unless you get 7 or more out of 10. Could we renegotiate that? Okay, I'll go to the gym 3 times a week. How likely are you to do that? 8 out of 10. That's going to happen. Now that's really crucial because, as doctors and nurses, we tend to think of, they're going to go to the gym 10 out of 10. Yeah. And their brain is saying to you, it's 5 out of 10. Their subconscious is telling you, I have no interest in doing that. And the first 35 years of my clinical practice were in cuckoo land because I never checked out with people. Always wondered why they didn't do it and sort of thought, well, they're a bit slack, aren't they? They didn't do it. But actually, I didn't check out. And since I check out with people, whether they're going to do things, they tend to do them. Or they say, look, I didn't do that, and I know I said I would, but I've done that instead.
Yeah.
So that's been my sort of experience.
You're creating commitment with them, aren't you?
Absolutely. And that's the acceptance and commitment part. The commitment part is that part. And then if you get people exercising, they by and large feel better afterwards. Depends how flat they are. So then you say, trust your experience, not what your mind's saying. Because our minds are very good in the practical problem-solving world, like fixing your car, paying your bills. They are very poor at personal things, like when you get distressed or depressed or you start having negative cognitions. So your brain will say, don't go to the gym, have a beer, have a muffin, sit on the couch and watch the rugby. When your experience is that when you go to the gym, you feel better.
Yeah.
So you have to remind people. So that's a big thing in ACT, is trust your experience, not what your mind's saying.
Yeah.
We have way too much faith in our minds.
Yeah.
They're only good for the practical world.
Yeah. And the acceptance part of fact, tell us a bit more about that.
Okay, so here's the thing. So I'll ask a patient, my favourite thing actually is when a patient bursts into tears, I have to say, because they're giving me their pain. And I say to them, if your tears were words, what would they be saying? Because they're saying, here, Dr. Bruce, is my pain. And it'll be something like unlovable or not good enough. So then I'll say to them, okay, now the problem is when you think not good enough, that scares your brain. And it's not because whatever happened to make you not feel good enough we're not condoning perhaps being bullied at work. But when your brain thinks that I'm unlovable, that'll scare the brain, and that's what's making you anxious and depressed, or whatever label we want to give it. And so then I get people to do a little mindful anchor, which essentially is exposure therapy against that feeling. So that's the acceptance part. So I'll say to them, to help your brain become accepting of being unlovable, we're going to do a little 5-step thing, and it's on a video on my website, but I could show you now. We can do it later if you like.
Well, why don't we go through it, because then it'd be good for people to see.
Okay, Helen, so let's say you were feeling unlovable. I would say, can you put your right hand over your heart? Let's get the anatomy right here. And your both feet on the ground, so you feel safely anchored, because we could be taking you through some, if it was a bullying at work, you might get quite upset at revisiting that. So we've noticed it. Bullying's in the room, we've named it. And unlovable's in the room. So I want you to just show a little bit of self-compassion to Helen at the moment. She's a really nice person, and just a little bit of self-love, the sort of kindness you'd show your 3 boys perhaps, that sort of love you would show them, that sort of kindness. Now it's interesting, at this point, you sometimes find people stall, and then you know there's a big self-compassion issue, and that requires another little bit of extra things, such as, what is the voice of kindness in your head? So
they're not even able to give themselves some
when you say imagine being kind to yourself, and so you have to ask them what the voice of, what's the emotional tone of the voice in their head. And invariably it'll be negative stuff. And then I invite people to cultivate the voice of self-kindness in their heads. And I'll say to them, I've had to learn to do this in my own life, which is you're allowed to self-disclose a little and act. And hopefully that will make people feel a little less like I've got my life sorted, you haven't, sort of thing. And sometimes that will require quite a bit of work on self-compassion. Then I'll ask them to put being unlovable on a seat across the room. And then I'll say, well, how are you feeling now? And usually people are feeling better by that point. Sometimes you might have wound them up. If they're feeling better, you then say, what's possible now? Because they're in the here and now. Not in the past, not in the future. They may be able to start saying, well, I could catch up with my friend Susan and have a cup of coffee, which is part of expanding life. Or I could go to the gym 3 times a week. So that's a pretty...
They're very practical things that everyone can do in a consult, aren't
It's
they?
not rocket science. You can start doing this on Monday if you want to.
And you can do it for a wide range of issues that your patient can come
I
up with.
use this all the time. I have to say, I've started asking teenagers what the emotional tone of the voice in their head is. And it's pretty scary, the stuff I've said. I had a young man say to me a couple of days ago in the office, I'm a piece of shit. This is a 17-year-old boy. And I thought, if that's what you're saying to your brain, no wonder you're anxious. That's scary stuff. That's like holding a gun to your head. No wonder this kid's very anxious. And I have to say this seems to be quite universal. But it's a nice narrative to get into a discussion with a teenager. They do engage. They do talk. Otherwise, they can be a little bit, sort of sitting back. So, what's the emotional tone of the voice in your head? You really get their attention, because they know it's probably not good. And that can be the start of opening things up for them.
And then you start these commitments, hopefully, that they can do with you, and then follow them up, Bruce.
I always see people within a week if I can. If they're very distressed, I sometimes see them a bit sooner. For very acutely distressed patients, I get them breathing.
Yeah.
It's the quickest way to put the brake on.
Yeah.
You activate the parasympathetic system by breathing. So the extremely distressed patient, you can't talk to them.
Yeah.
You just have to settle them down, just sort of decompress them, I think is the word I sometimes use.
Yeah. Oh, look, wonderful, Bruce. And I know there's a lot of resources, so we'll
Yep.
put them up, and a lot of reading that people can do around ACT and FACT.
Yep. And I run courses, so if people are interested, they can sign up to my mail base, and
Wonderful.
I'll let them know when courses are.
Great. Thank you, Bruce.